Extremely fortunate today that we have the pleasure of having our dear friend Dr. Anindra Kumar in this forum. He has previously presented many times on these issues. So our program is that Dr. Irfan Nazir, Professor of Urology in Lahore, is going to talk about a little current practice pattern in the management of BPH in our part of the world. Mr. Anindra Kumar is going to talk about the use of medical treatment following MIST procedures, and I'm going to talk about the use of MIST after TURP. So, little change in the program. We will be inviting Mr. Anindra Kumar first to make his presentation. And just to give you a brief introduction, what we are going to discuss today, this evening, is that male LUTS for BPH, as we all know, is predominantly now treated with medical treatment. And in certain situations or failure of medical treatment, interventional treatment like the minimally invasive surgical techniques for BPH or the classical prostatectomy is done. Some patients continue to have bothersome lower urinary tract symptoms even after these interventional treatment. And for these patients, we probably may at times need to re-intervene or use the same medical treatment that we have used prior to surgical intervention. So we're going to talk today focusing predominantly on these issues, which I think is a major medical concern for practicing urologist. So I'll stop here. I'll stop sharing my presentation. Mr. Kumar, you can upload your presentation.
Thank you very much. Again, thank you, Professor Hamadatkar, for giving me this opportunity to discuss on the post-MIST, what are all the adjuvant medical treatments available and why it is it needed, etc. I always appreciate Professor Hamadatkar for thinking some topics which were not usual. And it's not very common for even in the Western area, even if I take any European countries or American countries to discuss the topic of what is the utilization of the medical management post MIST. Because it's a very important topic, as Professor mentioned, but at the same time it is not at all discussed because we want MIST to work completely 100% throughout the life. But in real world experience, the fact is not so. So there is a need for adjuvant medical treatment. So the question is it correct? Is it ethical? How far we can gauge something as success or failure? These are all very, very personal things. For a surgeon who is quite passionate on the MIST like me, it's very difficult to say which is correct, which is failure, which is success, etc. I will try to talk as much evidence-based and also what I feel in my heart as the correct medical practice, because end of the day, our aim is to make a patient completely free of his symptoms and make his life as good as before. That is our main aim. Again, thank you, Professor, for this opportunity, and thank you for giving such it's a challenging topic, but at the same time, it's quite a unique topic. I really appreciate that. Now, as Professor said, I've spoken about this MIST many times, like Eurolift, iTind, etc. But as we speak, as we grow, in the past 1 year itself, we came across lots of other new energies. I will try to very briefly mention that's the topic of the energies. At least I wish the audience to know the title of what energies we are discussing on. And then I will focus on the actual crux of the topic, which is the need for the medical management post-MIST. What is the difference between this MIST and prostate cavitary surgeries? What I mean by cavitary surgeries or the prostate surgeries where we'll create absolute good cavity. So as you can easily say, the age-old gold standard is the TURP. And now the new gold standard, which is definitely going to be gold standard in the future, is the anatomic enucleation of the prostate. The difference between this cavitary approach, which is TURP or anatomic endoscopic enucleation procedures on one end with very good success relatively, and on the other end this minimalist approach of minimally invasive surgical treatment. The main difference is the MIST, as the name suggests, is quite minimalist. It's a very minimal procedure. Okay. So it can't be compared to something which requires anesthesia, which requires maybe transfusion, which requires catheter irrigation, overnight stay, etc. etc. And the other advantage of MIST is most of them can be done under local anesthesia, even though individually there may be some challenges with each. And they are very suitable for low performance status patients. What I mean by that, sometimes if the patient is very crippling, say bedridden, doesn't like catheter, or sometimes cognitively not good, pulling out the catheter, resulting in bleeding, resulting in urethral injuries, etc. MIST will be very handy because it's quite suitable for patients who are, I won't say unfit patients, patients who are quite poor in their fitness. And the main thing which stands above the TURP and cavitary procedure is ability the MIST can maintain both erection and ejaculation. Unfortunately, nowadays all the diseases were a bit preponed, and we can take it to anything. So if you take the average age in which the diabetic happens in 1900s, it will be around 50 or 60, etc. But now the average age of diabetics is, the starting of diabetics is coming to 40. Similarly, the hypertension, cerebrovascular accidents, cardiovascular diseases, everything there is unfortunately coming in one decade earlier. And similarly, the urinary symptoms also now occurring in young men at the age of even 35, 40, presenting with significant voiding symptoms. And when we do flexi, we can find sometimes quite tight bladder neck, etc. These are all due to the sympathetic tone and the lifestyle, which we can discuss in the other presentations. So for these kind of patients, it's very important for us to offer a procedure which will de-obstruct the bladder, but at the same time preserve the erection and ejaculation. I've come across some patients who need this MIST procedure, but they haven't even completed the family. Some of them have no children, some of them have one children, but wish to have at least 2 or 3 more. And it's very important for them to have this possibility of having the normal erection and ejaculation in spite of the bladder outlet obstruction procedure. Obviously, this MIST will not produce a cavity as big as the TURP or holmium enucleation or thulium enucleation procedures. But our aim with MIST is to create the cavity as big as possible, preserve the ejaculatory mechanism as good as possible. Those two are the main gold line, I will say. By not creating a cavity as big as TURP or enucleation procedures, by preserving the tissues to preserve the ejaculation, are we compromising on long-term results? My answer is yes. Definitely, MIST can't give long-term results as good as TURP or enucleation procedures because we are not doing the job as big or as destructive as the cavitary procedures does. Age old, say for example the days when I passed my board exams, we used to say the chances of failure of TURP in 10 years is approximately 10%. That rule is there, so even for TURP. Even TURP will fail if the patient lives longer because the prostate, whatever we have left out, will grow back. Even the holmium enucleation, even though the surgeon is very good up to capsular enucleation, there is a possibility of regrowth because the surgeon will leave some prostate tissues here and there. But fortunately, since enucleation is enucleation, we get much better cavity and the chances of the regrowth of prostate causing a good symptomatic recurrence in that patient's lifetime is quite remote. That's why the enucleation is going to be the new gold standard for present and the future. So now this has given a little bit of idea about where the MIST stands, why there is a failure, and where the cavitary procedures stands. And just to give the list of MIST, which is now well accepted by the guidelines, by FDA, etc. We have discussed quite extensively about Eurolift and Resume. When I came to Pakistan, the PAUS 2023 meeting also, we presented about both Eurolift and Resume. I've done a few times online also. The other thing which is now coming up very well is iTind, which I did with the Hyderabad section of PAUS quite recently. Possibly in the future also we will try to discuss a little bit more in depth about iTind. The other two MIST procedures which were growing very nicely are the Optilume and the Eco Laser. I don't discuss them much because the topic is different. So Optilume is a kind of a urethral balloon based device where we dilate the prostatic cavity, create a cut at the region of 12 o'clock, and by using the paclitaxel we create a kind of apoptosis to create the prostatic cavity. Again, there are beautiful videos, and if they have got enough opportunity, I will present Optilume on a different day. Similarly, Eco Laser is a thermal ablation by using the laser, and we'll discuss these techniques in detail on a different presentation. Why there is a need for MIST? First of all, let us just go through some basics. So the symptoms a patient presenting to us were broadly divided into voiding symptoms, storage symptoms, mixed symptoms, and retention symptoms. If you say voiding symptoms, it means patient has got symptoms like weak stream, hesitancy, interruptions, etc. We call it as due to bladder outlet obstruction. If you take storage symptoms, it could be due to two different etiopathology. The first one is secondary to bladder outlet obstruction. So if you do urodynamics, sometimes you can say that there is some hypercontractile hyperactivity in the detrusor, but it is secondary to bladder outlet obstruction. So these patients, if you do MIST, they do well because we are addressing only the bladder outlet obstruction. Indirectly, it will help the bladder to recover its contractility, and then it will help with the storage symptoms also. But sometimes the patients may present with pure primary hypercontractile bladder due to the lifestyle changes, caffeine intake, high pressure working, increased sympathetic tone, etc., etc. So those patients have nothing fault in the prostate. So whatever you do for the prostate, their storage symptoms should not improve. It's like apple falls due to the gravity. Whatever you do, that only will work. So the MIST procedure works only in the prostate. So if a patient presents with the storage symptoms, you should be absolutely sure that the storage symptoms are secondary to bladder outlet obstruction. Urodynamics is a very important tool in this aspect to be confident of this thing. If there is a storage symptom which is more bothersome for the patient, but the storage symptom is not the reason for the patient's bladder outlet obstruction, then obviously the treatment of bladder outlet obstruction will not help in the storage symptom. Patient will need some medications for the storage symptoms. So that I will discuss further. And then there comes the mixed symptoms. Again, mixed symptoms could be like a voiding dominant mixed symptoms, storage dominant mixed symptoms. Quite clear. Anybody with mixed symptoms, voiding symptoms will be addressed. Storage symptoms, if it is secondary to bladder outlet obstruction, they will be addressed. But if the storage symptoms are primary hypercontractile bladder, unfortunately, we won't be having good improvement with just MIST alone. Coming to the retention, it's now very clearly proven acute retention patients and to some extent acute on chronic retention patients do well with MIST. Especially in Eurolift, we have got quite strong evidence of Pulsar study where it has shown that acute retention patients, those with good bladder function preserved, they do well with the Eurolift. But chronic retention patients, again, the fault is not in the prostate. The fault is because of the bladder where the contractility is gone. So those patients will not respond to MIST, and not only will not, they should not respond to MIST because we are not addressing the primary pathology. And similarly for high pressure chronic retention, the pressure is so high in the bladder, it got transmitted via the ureter into the upper tract, resulting in the hydronephrosis and loss of the kidney function. These group of patients should not have missed. They should have absolutely cavitary procedures like TURP or any enucleation procedures, so that we create as much of low pressure in the bladder and we preserve the kidney function as much as possible. I hope this gives an overall idea of mainly two things. The mist will address only the bladder outlet obstruction problems. If there is a primary pathology in the bladder, mist will not work. And if there is a combination of the primary pathology in the bladder and something in the prostate or bladder neck, we need some ancillary medications. Okay? Now, the main four areas where mist were quite popular and why it's become very topic of the world is patients are not in need for TURP or holmium ejaculation. The prostate is not big enough. For example, if you start them on, say, tamsulosin, alpha blockers, it's brilliant. It's working very well. The patient feels like, doctor, I'm peeing like a horse. I have no problem at all. But the problem comes due to the side effects. Any medicines have side effects. So tamsulosin, as we know, we have side effects like, for example, postural hypotension, asthenia, nasal stuffiness, etc. Or in case if the patient is on 5-alpha reductase inhibitors like finasteride, it can cause problems like lack of libido, erectile dysfunction, etc. So patient says, doctor, my water works is brilliant. You have given me the tablet which really made me feel 10 years younger. But unfortunately, I have these side effects. So what to do? We can't force the patient to suffer from side effects, which is equally as bad as any voiding symptoms. So these patients will be served by mist. The other thing is failed medical management. Somebody will fail quite early itself, within 3 months or within weeks of starting the medication, stating that it never worked for me. But for some patients, these medicines work for 5 years, 10 years, 15 years and then stopped working because the prostate has overgrown or the patient's sympathetic tone has become different. Another thing is economics. Patients find difficult buying these tablets every day, week on week, month on month. They say, doctor, can you do one procedure? I'm happy to shell out some money and solve it. I can't pay this monthly pharmacy bill. And the most important thing, as we discussed, is these symptoms are now present in very young population, and those who want to preserve erection and ejaculation, our own tablets of tamsulosin, which can cause dry ejaculation, as we know, and also the finasteride, which can cause significant problems with libido and erectile dysfunction. The tablets are not doing any good. And here I want to explain clearly the side effect of tamsulosin of retrograde ejaculation is a little bit of a misnomer. So the best or the latest evidence is tamsulosin, just like how it causes relaxation of VUJ, relaxation of bladder neck, relaxation of trigone, relaxation of prostate. It also relaxes the ejaculatory duct. So it's more of an ejaculation, because for proper ejaculation to happen, the ejaculatory duct should have the preservation of the peristalsis, smooth muscle movement, etc. Tamsulosin, because of the alpha blocker, causes atonicity of even the ejaculatory ducts that results in anejaculation. So the side effect of retrograde ejaculation is very much outdated. So if you come across an examiner who is quite updated, they may quite ask you on these kind of aspects. So now, the need for the medical management post-mist comes into play because of the surgical retreatment rate after various new mist procedures. It depends upon which article, which resource you are looking into. This surgical retreatment rate varies. There are lots of sponsored studies sponsored by pharmacies. So if there is a study which is sponsored by pharmacy companies, say for example Boston Scientific, they may come out with a study saying that resume as the least retreatment rate, while others have more retreatment rate. And similarly, every company has its own publications. But I've just Googled and took this particular abstract from AUA from 2021, which showed on an average retreatment rate per year. The values are quite upsetting. Per year, the retreatment rate for Eurolift 5.4, TURP 5.3. So gone are the days where we say 10% retreatment in 10 years. Now there is a retreatment up to 5.3 every year. And green light again 5.2, resume 7.2. So there is a very big need for retreatment. There are various reasons behind it. Number one, maybe the surgeon may be in a learning curve. Number two, maybe like a wrong selection of the patient. Number three, maybe like a wrong technique. So there are lots of reasons for this retreatment rate. And as I said, if you look into a different publication from a different country or a different kind of practitioners, these rates will differ. But one common thread is there is a good amount of alarmingly high retreatment rate. This is one reason why professor asked me to take this topic to see what can we do for these patients who need retreatment. Or they really need to go for another surgery, or can we again balance it out by using some medical management. Now, any missed procedures, we can divide the patients into three groups. One group, excellent improvement. Patient discontinues all the medications. If the patient previously on a catheter, like acute retention patient, he is free of catheter, he really appreciates you, he comes and gives you a chocolate and a greeting card, patient sorted. How long he is sorted is another question. It may work for 1 year, 5 year, 10 year, we don't know. But at least patient had excellent outcome, patient is happy to get discharged and go back to his normal life. We want all the patients to be in this first group, which unfortunately won't happen in the real life practice. The second group is the moderate improvement, where they will say, doctor, I'm feeling okay. The nighttime symptoms are better. Previously, I used to get up 10 times in the night. Now I'm getting up only once in the night. It's better, but it's not, I won't say it's brilliant. I won't say it's 100 out of 100. So these kind of patients will get benefit from, say, alpha blockers or 5-alpha reductase inhibitors, anticholinergics or beta agonists. So this is the main crux of today's presentation. And this medical management, again, not necessarily the patient needs to take for long term. These medicines can be restarted maybe for even short term or maybe for slightly longer term. So this is where the question of whether the medical management after the missed procedure is really necessary. The answer is yes to selective patients with moderate improvement or unsatisfactory improvement. At the same time, which one to give? You need to re-evaluate the patient's symptoms. So patient may initially presented with significant mixed symptoms of voiding and storage. Now the voiding is completely okay. He say, doctor, the flow is brilliant, but unfortunately he still have frequency of symptoms. It takes some time for the bladder to get the retraining that there is no bladder outlet obstruction. There is no need for bladder to be hyperactive as before. So it takes some time even after TURP or Holmi enucleation for the bladder to improve. That's why a lot of patients with Holmi enucleation can develop significant stress incontinence, and it takes some time for the bladder to get retrained and the stress incontinence disappears later. So in that period, patient may need some anticholinergics or beta agonist, or sometimes even with a combination of tamsulosin. And also some procedures like, for example, iTind, it produces a lot of edema in the prostate. And initially, once you remove the iTind implant after 5 days or 7 days, patient will struggle and they need to continue the alpha blockers or 5-alpha reductase inhibitors, whatever the medicines they are taking, at least for a few weeks to get the confidence of voiding without tablets. In my practice, what I tend to do is, if I'm doing a Eurolift, if we have to do an iTind or resume any procedures, if the patient is already on tamsulosin or finasteride, I will ask them to continue at least for 3 to 4 weeks. And it really helps to kind of bridge the improvement and slowly wean off the tablets, rather than stopping the tablets on the day of surgery, putting the patient into multiple stress like local anesthesia, hospital visit, missed procedure, stopping 5-alpha reductase inhibitors, stopping the alpha blockers. Everything at one go spoils the patient's comfortness. Okay, so there is a definite need for missed either short term or long term. And I've come across some patients After Eurolift, they say, Doctor, the flow is brilliant. I'm very happy and thankful for this. I'm able to sleep well. There is no problem with erection. The ejaculation is maintained. Everything is fine. And then when you ask further questions, are you still taking tamsulosin? They will say yes. So if I ask you, why are you taking tamsulosin? Just stop them. I don't think you need them. They try to stop them, but they feel that added tamsulosin gives them more confidence. They are able to have good holidays. They have good flow, etc. They say, it's not bothering me anymore. I'm really struggled a lot with tamsulosin. It's never gave me the quality of life. Now with Eurolift, my quality of life is so brilliant. Why we have to stop the tamsulosin? Why can't I continue? And my side effects are not that bothersome. So there is a good group of patients where we may have to continue the medications in spite of the missed procedure. If I take back, say, 30 years back, 40 years back, if a patient had TURP, if the patient need to take alpha blockers post TURP, that means that's it. It's a failure of TURP, because we want TURP patients to be absolutely medication free and they should be completely voiding on their own. That's the success of TURP. But this mist is not as powerful like TURP or enucleation procedures. Since we are quite minimalist, we need some additive support from the medical management also. Unfortunately, sometimes you will come across the third group, which there is no improvement from the procedure. It's absolutely failed mist. Patient definitely needs TURP or anatomical endoscopic enucleation of the procedures. I hope with adequate patient selection and adequate training and appropriate mentorship, the third category should not happen. The third category happens means it may be a wrong patient selection or wrong technique selection, and those things should not happen in our normal life. So if a surgeon is completely nicely trained, he has know the pros and cons of all the missed options available, his outcomes should be like 70 to 80% in the first category. Excellent improvement, no need for medicines. 10% patients may need some support from medical management, and the chances of failure should be nil, maybe 1% to 3%, which can happen irrespective of the techniques, etc. Okay. So is medical management post missed means failure? I don't think so. So in the era of TURP, if a patient is going for a whole beam enucleation or any enucleation procedures nowadays, if there is a need for medical management after that, especially alpha blockers or 5-alpha reductase inhibitors, it's not a good sign. But sometimes the patients need anticholinergics or beta agonists because of the bladder symptoms. But for missed, sometimes patients may also need to continue tamsulosin and 5-alpha reductase inhibitors. I won't say it's a failure. It's a new norm. Maybe this is what we are discussing in the conferences. This is the feel from the surgeons who are doing quite high volume, minimally invasive surgeries for prostate. But whether it will be acceptable in long term, whether it will penetrate into the guidelines, etc., we need to wait and see. So we have discussed quite clearly how mist is differ from the TURP or anatomical enucleation of the prostate. Both are entirely different. Lot of times the mist is marketed as just an alternative to medicines. So instead of getting into the surgical realm with lot of side effects of, say, bleeding, need to stop anticoagulants, etc., etc., why can't we balance or bridge so that the patient will push the TURP or the whole beam enucleation to a later decade? Maybe it will save another 10 years of life. So mist bridges the life till little bit elderly age. It preserves erection and erectile dysfunction as long as the patient needs, which is the major winning post for the mist. And for many patients, obviously, it has become a very nice long-term solution also. So many thanks for this opportunity. I'm quite happy to answer the questions. Best wishes.
Thank you very much, Mr. Ananda Kumar. I think that's, as always, a very illuminative presentation. I think you have very nicely clarified some of the issues about adjuvant treatment. And I think the need for long-term treatment, and particularly your focus in defining that bladder dysfunction is one entity which can persist even after missed procedures. We'll take questions cumulatively on all three presentations at the end. We'll just ask Irfan, are you ready with your talk?
Yes, sir, I'm ready, sir.
Please post questions to Mr. Kumar's presentation on the chat box. And if you want to ask a question, we'll have hopefully time in the end to ask them personally. So, Irfan, you can share your presentation now.
All right, sir. Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Irfan Nazir. I am currently practicing in Lahore, Pakistan. And I'll be talking to you about the current practice patterns of BPH management in South Asia. Let me start by the overview of this presentation today, in which I will be discussing the demographics, the diagnostic tools and its utilization, the medical treatment options that are available in South Asia and Pakistan particularly, and then the therapeutic interventions, how they are used, and about their availability and cost effectiveness in South Asia and especially Pakistan. Basically, in disease prevalence change, is this graph visible to all of you?
Yes, Irfan, we can see your slides.
Yes. Disease prevalence change. In this, you can see that histologically, all of us know that BPH starts in the early 30s, and there's 1 in 10 men who develop BPH histologically when they're in their 30s. And this increases to 25% in their 40s. And then in 50s, it becomes 50%, and in 70s, the prevalence of histological BPH becomes 90%. So these are the patients who will definitively need some kind of intervention, either medical or surgical. This graph tells you, this table tells you basically about the disease burden, especially in Pakistan, in which you can see the highlighted white line shows you that in the Pakistani population, about 11.5 million patients are those who are aware and unaware of their BPH and who require some sort of treatment, which can either be medical or surgical. Now coming to how the diagnostic parameters are used, in our survey, we have found that IPSS is being used in mostly academic institutions. And also in the academic institutions, it is not being used as commonly as it should be. And the reason that I have come across in my survey is that people do not feel comfortable and they are not well aware of how to fill in this self-administered performer. However, it has been, the IPSS has been translated into Urdu language. I have given some references at the bottom of the slide. Despite that, what I have found is IPSS is maybe only used in 10% of the institutions. Ultrasound is being widely used, and fortunately it is available in nearly every city, even in some villages. And sonographers are good at saying that the patient has some post-void residue or not. However, only a few sonologists are aware of the role of the median lobe, and only a few of them document it according to the classification that is present. However, some urologists, even in my survey, I even found some urologists who were not aware of how the median lobe affects the symptoms and their management. Frequency volume charting is very rarely used, and in all my survey, only about 10% practitioners were using frequency volume charting in patients where it was indicated. This slide tells you the presence of uroflowmetry facilities across the country. If you can see in Karachi, there are 6 centers who have uroflowmetry. In whole of Balochistan, there is no single center which is equipped with uroflowmetry. In Lahore, there are 4, and Islamabad 2, and Khyber Pakhtunkhwa also, I was able to find that there were only 2 institutions which had uroflowmetry available. Now, this might not be an actual representation. This is what I have come across in my survey. The actual situation hopefully will be better. Similarly, in urodynamics, Balochistan has no availability of urodynamics. Karachi has 4 centers which are equipped with urodynamics. I'm sure Hyderabad and Larkana might also have, but in my survey, I could not get that knowledge. And there are 3 centers which are performing urodynamics in Lahore, and 2 in Islamabad and 2 in KPK. Medical treatment, I was able to, most of us are using lifestyle modification advice. By that I mean restricting fluids in the evening, withholding of caffeinated drinks and cold drinks, etc. And double voiding. These were the most commonly advised lifestyle modifications. Now, in a slide, if I can tell you about the Pakistani population, according to the current census, it is 241.5 million that the population stands at. The bladder outlet affected population out of that is 11.5 million. In the last survey of the GDP, the average household income came out to be 41,545 rupees. And the average household size comes to 6.4 people per house. So per capita, the revenue that each person has for themselves is sadly 6,500 rupees. Now, alpha blockers, we have terazosin, doxazosin, alphazosin, tamsulosin, and silodosin available. The average daily cost of an average alpha blocker is around 61 rupees. So that will cost a monthly of 1,830 rupees. Now remember, this is out of the 6,500 rupees that the person has in total. Similarly, anticholinergics, we have flavoxate, tolterodine, solifenacin, and darifenacin is also now available in some very restricted areas. The average cost of this is around 70 rupees, and per month cost obviously comes to 2,100 rupees. 5-alpha reductase inhibitors, finasteride costs about 65 rupees per tablet, and dutasteride costs about 82. So using this will also cost around 2,500 rupees per month. The combination therapies, we have alpha blockers plus 5-alpha reductase inhibitors. The approximate cost is around 110 rupees per tablet. So this will come somewhere around 3,500 rupees. The cost of the tamsulosin and solifenacin, the anticholinergic, the combination that is about 129 rupees per tablet, which comes to around 4,000 rupees per month. Beta-3 agonist, 5 milligram is available at 62 rupees and 10 milligram at 95 rupees. So that will also cost somewhere around 2,000 to 3,000 rupees per month. Now, I will again reiterate that all of these costs are from a total of 6,500 that is available per person. Now, coming to the interventional options, TURP is now divided into monopolar and bipolar options. Monopolar is widely available as nearly every hospital has a diathermy available in their machinery. And now that we have a lot of trained urologists who are even working at district levels, monopolar TURP is available very widely. Bipolar, with having the advantage of less bleeding, more hemostasis, use of saline, less TUR syndrome, is available in only the major cities and in some public sector hospitals. Laser evaporation has been used, the diode laser evaporation, and it is being used in some tertiary care hospitals, but the use is not very common. In Lahore, only 2 to 3 specialists are using it. In Islamabad also, there are only 2 to 3. In Karachi, I hear that only 2 or 3 people are using it. Most of the people have gone away from using it because of the high cost. And there's irregular supply of consumables. The fiber only works for 2 cases. And then there's also lack of the machinery, the diode laser, and obviously also lack of trained surgeons. Some people have expressed their concern that laser evaporation causes irritative symptoms because of which they do not like performing this surgery. Coming to HOLEP, it is only being sparingly used in a few centers because of unavailability of high-powered lasers, as mostly this can only be done in lasers which are 80 watts and higher. So the high-powered machines are usually not available in most of the centers. There is obviously a lack of training. Our Khan Institute also has some skills lab training program over there, and they are doing a great job in teaching people HOLEP. However, there's improper mentoring program available in Pakistan. And obviously, as the learning curve is very steep, there's fear of complications. And also there's fear of having incontinent people. So that is why HOLEP has not really taken off in Pakistan. There is Resume that has been started in one center, and in my chat with them last time, they have done about 30 cases in 2 spells. They did 15 cases. There was some problem with the machinery, and then it went for repair, and now it has come back. So they say in the first 15 patients, their experience was better than the second 15 cases. The cost is obviously very high, at about $2,000 per disposables per case. And obviously there is only a single machine that is available in Pakistan. So the widespread use obviously is not available. Robotic surgery is being done at one center in Karachi, and they have published some articles about doing robotic surgery for large prostates. Prostate artery embolization is only available in 3 major cities, that is Karachi, Lahore, and Islamabad, and there are only few trained operators who can effectively do the prostate artery embolization. Open prostatectomy is still being done by general surgeons and only being done for very large prostates by urologists. Now, the restricting factors for minimally invasive prostate surgery in Pakistan are the cost, lack of availability, lack of trained surgeons, and fear of retreatment in terms of expense. So this is what I came across in my survey, and I would gladly answer any questions that are asked. Thank you.
Thank you very much, Irfan. I think you've provided a very good background of what's happening across Pakistan. And obviously, there are bigger centers, bigger hospitals in some of these cities where a lot of things are available and practice is very similar to what happens in most part of the world. However, there is significant need for basic urodynamics like a uroflowmetry. Fortunately, some of the centers which are probably not mentioned in your diagram have identified, and I've asked them to identify if uroflowmetry and urodynamics is available in those centers. So maybe it may add to your survey. So if you can unshare.
Yes, sir.
Please, thank you. Okay. I hope my slides are visible.
Yes, sir.
Okay, right. So as last part of this today's conceptual basis of urology course, and I'm really thankful to 2 nice presentations by Irfan and Ananda Kumar, in which Ananda particularly explained the background of use of medical management in the minimally invasive therapeutic options for BPH. I'm going to focus on the still probably the gold standard TURP. We know that this is the famous diagram from the European Association of Urology guidelines about LUTS, which is a multifactorial factor. And we need to do some basic workup to make sure that we are dealing with bladder outlet obstruction before every aging male is considered as one suffering from BPH and treated with one tool, which is either medical management or TURP. So if you look at the data, long term, and Ananda also alluded to it, that if we compare TURP with some of the other options, and some of these options are not commonly practiced these days, and the data, which is real longitudinal data of follow of up to 22 years, indicate that TURP indeed is a very durable procedure, but maybe not as durable as we always thought it is. So PVR reduction, improvement in Qmax, the IPSS score reduction, and quality of life indices is all in the range of about 70%. So we have significant improvement in all these aspects. Qmax improves, as is explained, by 162%, which indicates that the bladder outlet obstruction is at least released by this procedure. Well, there are unhappy patients, as you all know, and these unhappy patients include patients who have acute complication, which include bleeding, infection, and UTI, urosepsis, even chronic complication, incontinence, erectile dysfunction, ejaculatory dysfunction, and strictures, bladder neck contractures, stenosis, etc. But also, more importantly, the storage, voiding, and post-micturition LUTs, which are bothersome to the extent that some of these patients present back to you for addressal of these issues. Well, we need to understand why this happens, and partly it's explained by Mr. Ananda Kumar in his presentation, that male LUTs in bladder outlet obstruction results in overactive bladder, which is detrusor overactivity on urodynamics. And sometimes this ultimately leads to underactive bladder and detrusor dysfunction, which is a consequence of long-term obstruction. So this may result in persistent LUTs. There is 20 to 50% patients who potentially presents with LUTs following TURP. Various different techniques of doing TURP, monopolar TURP or bipolar TURP, etc., have more or less similar incidence in recurrence of LUTs. And it is probably related to the remodeling of the bladder, which is the reason for development of lower tract symptoms. Now, if you look at some of the predictors of persistent lower tract symptoms after TUR, age is one of the important factors. And we know that age has a significant impact on bladder. The baseline LUTs, if you had high baseline LUTs, it's likely to recover less than patients who have minimal LUTs. If there is significant intravesical protrusion, which results in significant mechanical obstruction of the bladder outlet, these patients also have persistent LUT for. There is now some indicators of nerve growth factors, which can be used as markers, biological markers, to identify these patients. This is data from Japan, and it clearly shows that TURP results in improvement of obstructive symptoms or the voiding symptoms in over half of the population only. And we actually were made to think it is much better than that. But look at the green bars, and you can see that the recovery of the storage symptoms is even less. So nocturia, which is a very bothersome symptom, is only improved in about 20%. The use of this is data coming from Canada, and as you can see, that significant proportion of patients with passing years required medical treatment, something that we give prior to TUR, and things that they are no longer needed. at least immediately afterwards, but these patients would require both 5-ARIs, anticholinergics, and alpha blockers. As I've said, nocturia is a major issue, and if you see that improvement in nocturia is only in about 20% of patients. This is a paper published in European Urology some 10 years back, and it essentially looks at a very important aspect, that what percentage of people would live during their lifetime after TURP or some other interventional procedure would need another something for lower urinary tract symptoms. So open prostatectomy, the chances are least, but obviously we know that we do very little open prostatectomy these days. TURP and HOLAP and thulium enucleation are probably closely matching. But some of the other procedures, some of which are no longer used, like microwave thermotherapy or needle ablation of the prostate, have a far higher chance that they would require some additional procedure during their lifetime. Again, a very similar study published in the Scandinavian Journal, the Neurourology and Urodynamics. And this data essentially indicates that patients who require medical treatment are at highest risk of needing another intervention after a TURP. So this is a long-term data going over 10 years, and it essentially looks at what percentage of patients would require another procedure. And one of the factors that they have identified is the use of medical treatment. And as I've said and showed you from the Canadian data, that with each passing year, the need for medical treatment keeps on increasing. So the chances of requiring another intervention also. Now, the question is that why does it happen? Is there a problem in our diagnosing the condition of bladder outlet obstruction and attribute it to the prostate? Well, we know that the epithelial and smooth muscle tissue are mechanosensitive. So mechanical stretch from, say, coming from bladder outlet obstruction can result in various modifications in expression of genes and protein synthesis in the bladder itself. And this would alter the ultrastructure and physiology of the cell membrane, the cytoskeleton, the contractile proteins, mitochondria, etc. And all this results in some permanent dysfunction in the detrusor and the epithelial cells of the bladder, which can result in persistence of LUTS for years after the bladder outlet obstruction has been taken care of. So what we use currently for diagnosis is uroflowmetry, and the classical cutoff is less than 10. And if you have less than 10 mils per second, you are probably one who needs some interventional treatment. However, we need to remember that about more than a quarter of a patient with decreased flow rates are not obstructed, and this is coming from subsequent invasive urodynamic testing. It is difficult for just looking at the uroflowmetry to decide whether this patient has got an impaired detrusor contractility, which is secondary to some of the neurological and non-neurological causes, or is it an obstruction? So synchronous measurement of the detrusor pressure on urodynamics cytocystometrogram is important to really define why there is a low Qmax. The presence of large post-void residue is again another surrogate marker that is used in our day-to-day evaluation of patients with BPH. It's more indicative of detrusor failure rather than an outlet obstruction, though. So it should not be used as a marker of obstruction. 50% of unobstructed men with low urinary tract symptoms have significant or elevated post-void residue, and there are other causes for it. And up to 1/4 of the severely obstructed patients would not have a significant post-void residue. So again, using these markers in isolation is not correct. So, what is then the gold standard in the diagnosis? And we know that urodynamics is is the way to diagnose whether you're really obstructed or the bladder dysfunction or the low flow max is due to something else. However, if we look at in detail, and I'm not going to go into each one of these indications, most of these are very limited indication for doing urodynamics in the regular practice. And maybe I'll come back to why that it is so, is because the level of evidence available for most of these indication is low. We all remember this work from Paul Abrahams and Griffiths of defining the various indices, the bladder outlet obstruction index, looking at some of the CMG parameters and the flow rates, and defining whether you are unobstructed, obstructed, or you are in the equivocal range. And most of the modern urodynamic machines actually give you this graph, and you're plotted as soon as you do a uroflowmetry. Similarly, the bladder contractile index, again, proposed by Paul Abrahams, which is essentially the detrusive pressure at Qmax plus 5 Qmax. And if you have a BCI index of greater than 150, you've got a strong contractions. Normal is between 100 and 150, and then weak is less than 100. This is a trial which called the Upstream trial, which is urodynamic for prosthetic surgery treatment. And it is an interesting study in which the regular care was compared in a randomized controlled fashion with the with the care in which urodynamics is also set in men who have low urinary tract symptoms suggestive of bladder outlet obstruction. And what was noted by the investigator is that urodynamic was non-inferior to the routine in a randomized trial. A lower surgery rate in UDS was not found. So we may think that if you do urodynamics, you probably would refine your indications for intervention for prostate. However, in this study, at least, it wasn't demonstrated. The adverse events were similar in the two arms. There were more cases of acute urinary retention in the routine care arm, in which the urodynamics was not done. So essentially, the author concluded that urodynamics evaluation and the diagnostic are not really required in routine fashion for most patients. And they have identified a group of patients who would do well with surgery, are those who have a high symptom score, who are under 74 years of age, Qmax of greater than 10, and BOI of greater than 48, and BCI of more than 123. So these are some of the parameters which you can use in your practice to define whether your patient is going to do well or not do well after surgery. Now, interesting paper by Welk, published 5 years back in Urology, the Gold Journal. They have made some hypothetical scenarios and shared this questionnaire, detailed questionnaire, to the practicing urologist. The first scenario was a symptomatic large PVR and detrusor underactivity. The question was that if you do a TURP, 76% patient offered TURP in that patient in this group. And they have quoted that the chances of improvement is about 57%. So, and about over 60% thought that the need for CIC if they don't do a TURP in this group of patients. When would you more likely to do a TURP in this setting? And the majority voted that mild to moderate hydronephrosis, history of frequent urinary infections, and mild chronic kidney dysfunction are some of the reasons when you do. In the second scenario, again, catheter-dependent patient with only evidence of detrusor overactivity on urodynamics. And again, significant proportion did voted in favor of TURP. And I'm going to skip some of the other scenarios for time because we're just running out. So I'll try and come back to my conclusions. So what we need to understand that bladder outlet obstruction, in the bladder outlet obstruction, bladder itself is not a silent bystander, it suffers. There is chronic muscular overactivity, which results in muscle fatigue, increased muscle mass and interstitial dysfunction. Progressive ischemia, inflammation, oxidative damage results in fibrosis. Impaired sensation and contractility is a consequence. And all this results in detrusor overactivity and with time, detrusor underactivity. This is the famous Chancellor theory about what happens to bladder. So there's a normal bladder which undergoes normal aging process without any significant symptoms, or it becomes overactive bladder, and overactive bladder can undergo various paths. If it progresses and patient is treated for detrusor hyperactivity, it may result in detrusor hypocontractile state and underactive bladder with time. So why it all happens? Are we prescribing one thing for all bladder outlet obstruction? So there is obviously not one size which fits all. We need to take into consideration various factors, which are not only include patient factors, prostate factors, the value and preferences, and that open up the arena of the various myriad of procedures which are now available to us. So the approach should be horses for the courses, and vaporization have their indication, enucleation procedures have their indication, TUR has its own indication, and as we have seen in Dr. Kumar's presentation, that MIST is again something that... Now, the second question that I wanted to address in this presentation is about, are we prescribing these medical treatments for far too long? And although they are providing some symptomatic relief, bladder is taking a toll. And ultimately, when they do end up having a TURP, their outcome is not as good as probably expected. And this article, I think it's worth reading, published in British Journal of Urology, looking at the various time frames in which the indication for intervention and the time for intervention is studied. And as we see with passage of time, the delaying TURP or other interventional results in perioperative, preoperative adverse events, poor immediate short-term outcome, and high rate of postoperative complications. So this is something that we probably need to understand, that although medical treatment is the first line, sometimes we delay too long. So in summary, bladder outlet interventions treatment do not always cure LUTS, be it the outlet reduction surgeries like TURP and OLAP, etc., or the minimally invasive surgical options. Age is another factor, and which obviously have a significant impact. Duration of disease, delayed definitive treatment, and obviously in the end, it's very important that you make your diagnosis right before you do any intervention. So I thank you very much, and I'm sure there are many questions now. Okay, I'll look at the questions, and in the meantime, if you have any comments.
Yeah, thank you, Professor. I try to answer as many questions as possible as the next two speakers are completing, and good discussions. The audit is very good. This kind of audit should be repeated maybe in another 3 years' time or 5 years' time to see the improvement in the practice. These national audits, especially, this can be led and guided by the PAUS itself. And for example, we have quite strong audit arm in our British Urology Association that will really help us to get the clear picture and also help the trainees to know what is happening and what needs to be done, especially in the areas where the facilities were not available. And your presentation is quite illuminating. It's quite clearly said that sometimes patients may not be symptomatic, but the bladder may be suffering in silence. Unfortunately, these patients are almost impossible to diagnose in the community, and we need to be quite vigilant in giving early intervention, and just continuing the patients on medications will only lead to secondary problems in the bladder, like as you said, initially a hypercontractile bladder and later maybe like a contractile bladder. I will say this is something to do with like our cardiac pacemakers. So our bladder has got its own pacemaker, and it modulates the pressure produced by the detrusor to empty the urine based upon the obstruction automatically. As a man gets older, once the prostatic obstruction slowly ascends, then the bladder's internal pacemaker sets at a higher tone, resulting in hypercontractility. That was also a part of the reason for the storage symptoms, and that's why a lot of patients with storage symptoms secondary to bladder outlet obstruction, once a bladder outlet obstruction is treated, slowly the storage symptoms also improve. But unfortunately, if the gentleman requiring treatment or underwent treatment quite late, as you correctly mentioned, that hypercontractile detrusor will end up forming the interstitial fibrosis, and that's where the acontractility sets in. There is a good evidence to say that the Holmi enucleation, because of its excellent deobstructive capacity, has some good role in hypocontractile or even acontractile detrusors. So we got quite powerful armamentariums. We got minimalist approach also. We need to use the instruments quite wisely. That's the main take-home message.
Thank you very much for your explanation, and I see that you have addressed almost all the questions while I was making my presentation. Nazim asked if there are any studies showing role of alpha blockers after resection of prostate, bipolar or monopolar TUR or holmium. Well, I think if you are asking it as an adjuvant treatment to these interventional treatments, no. Because that's what Ananda has also pointed out, that no sooner you've done your TURP, you would stop all medical therapy, alpha blockers, etc. However, patients who continue to have symptoms are the ones who probably would require some form of medical treatment, as indicated in the data coming from the Canadian study and the Japanese study, that patients who continue to have significant storage symptoms, they do require something. So no use of alpha blockers post-TUR or HOLAP does not improve overall and long-term outcome, if that's the question. So I think there are no more questions. We have already exceeded our time. So thank you very much and have a very good evening to all of our participants. And thank you very much, Mr. Ananda Kumar Dhanasekharan, for again, a very nice presentation and good explanation. And Irfan for sharing all that data, because I think it's important to understand what our limitations are, and only then we can work on how to improve upon that. So thank you very much and have a very good evening. Good night.
Thank you, Professor, and see you in Paris in a week's time.
Absolutely. Take care.